coming to this afternoon's master's class titled, How Can the Number Needed to Treat and Number Needed to Harm Inform My Clinical Decision when Treating Patients with Bipolar Depression? I'm Parth Sachdeva as a Medical Science Liaison with Synovian Pharmaceuticals, and here today I have with me Dr. Citrome, Clinical Professor of Psychiatry and Behavioral Science at New York Medical College in Valhalla, New York. Dr. Citrome is a consultant of Synovian Pharmaceuticals. In today's program, we'll be evaluating the story of how the analysis of number needed to treat and number needed to harm tells the story in terms of evaluating therapies available for treatment of bipolar depression. So we'll get started. Dr. Citrome, can you start and can you tell us how do we calculate what is NNT and what is NNH?
I'll be happy to. Thank you for having me here today. This is one of the things I'm really excited about because it's a way of determining how important a clinical trial result may be. And we're given graphs that something is better than something else, let's say drug better than placebo, and we're given a p-value less than 0.05, and we're expected to say, okay, this is important. But you know, what you really need to determine is the number needed to treat, and this is an effect size. It determines how important that result can be. Number needed to treat answers the question how many patients needed to be treated with one intervention versus the other before expecting to encounter one additional responder, for example, or one additional remitter. So the lower the number needed to treat value, the better drug A looks versus the alternative. And number needed to harm is looking at outcomes we would rather avoid. So let's say how many patients needed to be randomized to drug versus placebo, for example, before expecting to encounter one additional patient who has excessive weight gain or an additional adverse event of somnolence, for example. So number needed to treat, number needed to harm are effect size measures and helps us figure out what these percentages mean, what this difference between drug and placebo means in human terms, in patient units.
Thank you for that overview, Dr. Citrome. Can you tell us how do we calculate NNT?
So it actually sounds pretty mysterious, but it's very straightforward. All you need to know to calculate the number needed to treat for, let's say, A versus B on an outcome that you're interested in, like remission, you need to know the percentage of patients on drug A versus drug B who were remitted. So two percentages. Now drug B can be, by the way, placebo, it doesn't have to be another drug. And what you want to do is subtract these 2 percentage points and then see how many times it goes into the number 100. So you take 1 divided by the difference in percentages. You'll also round up because the lower the number needed to treat, the more powerful it is. And you don't want to exaggerate a difference. So a number needed to treat of 3.1, if we round it down to 3, that sounds better, but it may be inaccurate. So we'll round it up to 4, err on the side of caution. So let me give you an example. Drug A results in remission 50% of the time. Drug B, let's say the placebo control, results in remission 20% of the time. Relatively speaking, it's 2.5 times better, but that doesn't answer the question, how often will a clinician encounter a difference in day-to-day care of people with that disorder? Well, very simple calculation. You have 2 percentages, 50 and 20. Subtract them, you get 30. That goes into the number 100, 3.3 times, rounded up to 4. For every 4 patients who are given A versus B, you'll encounter one additional remitted patient, and that will probably lead you to select A over B under most situations, unless, of course, A is not tolerated well or not accessible, not on the formulary or whatever. But otherwise, A is better than B, and this is going to be clinically relevant because you're going to encounter this difference in day-to-day care of people.
Oh, thank you, Dr. Citrome. You did mention about the power of the NNT. Can you tell us what's the magnitude of NNT and what's a good NNT number to look for?
So any number needed to treat value less than 10 represents a single digit and represents an effect size that is substantial enough to be able to be observed in day-to-day practice. If it takes 5 patients, 6 patients, 7 patients, 8 patients on one drug versus the alternative to encounter a difference, you will encounter that difference in day-to-day practice. Now, the most powerful NNT that we can see in medicine is 2. You can't have an NNT of 1 because nothing is perfect. So 2 is the best NNT you can see, and it's very unusual. NNTs of 3 represent a strong effect size. NNT that is, let's say, 8 or 9 is a weaker effect size. Any number needed to treat value that's a double digit or triple digit generally means you won't see that outcome very often in day-to-day clinical practice and is less important.
Now, can we speak more to number needed to treat NNT for treatment options for patients with bipolar depression for approved therapies?
So this is where it gets interesting because we can actually use this information to look at clinical trial data and come up with some very interesting conclusions about the efficacy of current therapeutic options for bipolar depression. Olanzapine-fluoxetine combination was the first to be approved by the FDA for this purpose. There's a certain percentage reported as having responded on drug versus placebo, and here in this case fluoxetine monotherapy. And you can subtract these two responder rates and see how many times it goes to number 100, round up, and you end up with the number needed to treat of 4. So for every 4 patients randomized to OFC, olanzapine-fluoxetine combination, versus fluoxetine alone, you would expect to encounter 1 additional patient who has responded. Hey, that's quite reasonable, and this is something I'm going to consider using in day-to-day practice based on efficacy. What about quetiapine? Similar calculations, NNT that is slightly higher, meaning less powerful. Remember, the lower the NNT, the better. Here an NNT of 6. Lurasidone monotherapy and adjunctive lurasidone when combined with lithium or valproate, NNTs of 5 or 7. All in the same ballpark, and importantly, when you calculate the 95% confidence intervals, you're going to see overlap, and we would say, hey, efficacy-wise, these interventions work in bipolar depression. So I'm happy to see those NNT values. They're all less than 10.
Now, we mentioned your introduction about number needed harm. Can you provide us some insight about number needed harm or NNH?
So the flip side of a therapeutic benefit is a harm, basically. And here we want to see how many patients need to be treated with one agent versus another before expecting to encounter a problem. And here we want the number needed to harm value to be high. We don't want to encounter that problem with the intervention we've selected. NNH is calculated the same way as number needed to treat. It's used to refer to undesirable outcomes like weight gain of at least 7% from baseline or 1 additional patient with sedation. The higher the number needed to harm value, the less likely one would expect to encounter 1 additional adverse event that we would certainly want to avoid. So although low numbers for NNT are what we want, low numbers for NNH we do not want, because it would mean that we would encounter a problem pretty frequently.
Okay, so one we need to be lower number, one need to be higher number NNH. How do we put it in perspective in terms of the specific therapies or example of an adverse event?
So here's where I'd like to turn to some off-label therapies for bipolar depression. Lamotrigine was never approved for the indication of bipolar depression, even though it is commonly used for that purpose, because the number needed to treat value to encounter 1 additional responder was 12. It's weak, it's above the number 10. I mean, it can be used, but chances are it's not going to work as well as the approved therapies, which have single-digit number needed to treat values. When we look at the number needed to harm for the most commonly encountered adverse event of sedation somnolence, the number needed to harm is high, it's 37. So this is probably the reason why lamotrigine is used. There's no downside really other than the very occasional patient who has sedation or somnolence in the hope of encountering response where maybe other things didn't work out and so on. Antidepressants, similar story, but here the effect size for efficacy, number needed to treat, was 29. Very weak effect size for efficacy. The number needed to harm, though, for a problem, let's say mood switch, 200. Hey, that sounds pretty good. You know, you're not going to encounter a mood switch all that often. But here's the rub. With a mood switch, you might have a harm that is life-altering. Someone has a manic episode, and they may be more likely to engage in behaviors that are self-destructive, that will harm their employment opportunities, their social life, their marriage, and so on. So definitely something you want to avoid. So even though it's 200 and you're not likely to encounter it, I don't want to encounter it at all. So maybe 200 is not high enough for that number needed to harm value to meet my comfort level.
Let's look at some specific examples of the adverse events of the approved therapies for bipolar depression.
So let's look at the approved bipolar depression therapies. Let's look first at olanzapine-fluoxetine combination and then at quetiapine. Well, we've already talked about the number needed to treat. They're fairly good. But what about number needed to harm for the most commonly encountered adverse event? We can look at weight alterations with olanzapine-fluoxetine combination. We know olanzapine is associated with weight gain. It's a given. How often did this occur in excess of 7% from baseline? Well, almost 20%. How often did it occur on placebo? Almost never. You calculate the number needed to harm, it's a 6. Not very far off from the number needed to treat value, demonstrating benefit. So you're going to encounter really weight gain pretty much as often as you would expect therapeutic effect. With quetiapine, it's even more extreme because the NNT not as good as 6, not as good as 4, 6, but still not bad. The number needed to harm for sedation or somnolence is 3. Based on the subtraction of the rates of somnolence for quetiapine versus placebo, you end up with number 3. How do we do that? Well, 56 minus 14 is like 40 something. That goes into 100, 2 and change, rounded up to 3. For every 3 patients randomized in the studies for quetiapine versus placebo for bipolar depression, you would expect 1 additional patient with a complaint of somnolence or sedation. That's actually twice as often as response in terms of looking at number needed to harm of 3, number needed to treat of 6.
As a clinician, I see number needed to treat, number needed to harm. How do I put this all together as in a context?
So we need to look at these adverse events that are important to the individual patient. Not everyone is going to be gaining weight or worried about weight, and so it's not going to be on the table. So we have to look at the whole array of adverse events and see what the patient is most concerned about, what they would prefer to avoid the most. So it's interesting to look at the long list of adverse events in these product labels and try to figure out what these percentages mean. And we can calculate the number needed to harm based on that. And for weight gain as a complaint, the number needed to harm of 7. For diarrhea, number needed to harm of 9. For dry mouth, asthenia, increased appetite, and tremor, the number needed to harm values are double digits, but they're low double digits and they may come into play. So this is how we can use it for olanzapine-fluoxetine combination. For quetiapine, with the next slide, we're going to see a different array of adverse events, starting with somnolence or sedation, where we already talked about the number needed to harm of 3. Dry mouth, though, the number needed to harm is 4. Now, not everyone gets somnolence, not everyone gets dry mouth, and not all of it is moderate or severe that requires any intervention. So it really does depend on the individual circumstances of the patient, but you can pretty much expect that these are going to be common problems. The other adverse events that have a number needed to harm values that are low double digits may also come into play, but certainly less often. And now when we take a look at lurasidone monotherapy, we can see the rates of nausea, akathisia, somnolence, extrapyramidal symptoms, vomiting, and so on. Look at the rates on drug at various doses and compare that with the rate with placebo and calculate the number needed to harm for both dose ranges. And you know what? They're all double digits, which means you are not going to be very likely to encounter these harms in routine use, and especially with the lower dose range. So interesting information that you can calculate from otherwise very boring lists of side effects.
And we're going back to looking at both number needed to treat and number harm for all the therapeutic agents available for treatment of bipolar depression. How do we compare them? Some of them have low NNTs, high NNTs, low NNH, high NNH. How do we compare them?
Well, so we've only so far talked about olanzapine-fluoxetine combination and quetiapine in detail. I'd like to review now lurasidone monotherapy and adjunctive lurasidone with lithium or valproate. And we already know the number needed to treat values 5 and 7, reasonable NNTs, they're single digits. Let's look at the most commonly encountered adverse event for each type of use of lurasidone. As a monotherapy, the most commonly encountered adverse event is going to be akathisia. When we look at the rates of akathisia for lurasidone and placebo, subtract them, see how many times it goes into the number 100 and round up, we end up with a number needed to harm of 15. Hey, that's a double digit. It's not like the single digit number needed to harm values that we noticed for the alternatives. So indirectly, we can compare lurasidone in this manner with the other choices and say, okay, I'm going to run into response more often than a problem with lurasidone than with the other agents, where I'll run into the problem as often as efficacy. Adjunctive lurasidone, the number needed to treat of 7, compared with the number needed to harm of, in this case, 16 for the most commonly encountered adverse event of nausea for those studies, I'm still going to encounter a benefit more often than a harm. And I know this based on this kind of indirect comparison, looking at number needed to treat values and number needed to harm values for each of our available choices approved for bipolar depression.
That's a very good point, Dr. Citrome. You're mentioning the indirect comparison of approved therapies for treatment of bipolar depression based on NNT and NNH. How can we go for one single agent and looking at the benefit and risk for the patient? If you have to look at one of the drugs, how would you do that?
So we can use the concept which I've talked about informally. We can put a name to it. It's called likelihood to be helped or harmed. And it's really the ratio of NNH to NNT. It answers the question, how much more likely am I going to encounter the benefit versus the harm? And you can select whatever benefit you want, as long as it's expressed in percentage terms. You can subtract them and see how many times it goes to number 100 and round up. You can calculate the NNT. And you want something with as small of NNT as possible. On the flip side, you want a number needed to harm that's as high as possible for whatever outcome that you would like to avoid. And you can choose whatever you like. So you can choose the most commonly encountered adverse event with the drug. You can choose the adverse event that the patient is most worried about and then be able to give the LHH for that specific adverse event and give that information to the patient. Oh, you're 5 times more likely to encounter a benefit than going to feel a little tremulous. So you can put it into that context based on the data from the clinical trials. The larger the NNH and the smaller the NNT, the larger the likelihood to help or harm.
So this gives a very good perspective of looking for each individual patient, what's the likelihood of having risk versus the benefit.
Yes, and before we move on, there is a harm I want to point out that's very interesting. How many patients had to discontinue a clinical trial because of an adverse event? That gives an overall metric of overall tolerability. When we have that data, then we can calculate the number needed to treat for benefit, the number needed to harm to stop a drug because of an adverse event. That's a very interesting number, especially to clinicians who don't want to give drugs that they have to stop all the time. So let's put all this together for the approved treatments for bipolar depression, as well as mention a few of the unapproved uses just for illustrative purposes. We have number needed to treat values in the single digits for the approved products for bipolar depression. We have double or triple digit number needed to treat values for the unapproved interventions that sometimes are used, including aripiprazole and ziprasidone, by the way, never approved for bipolar depression, sometimes used for that purpose, but the number needed to treat values would predict that we would never really see a benefit in day-to-day practice. So let's focus on just those agents approved by the FDA where there is proven efficacy, number needed to treat values in the single digits, and let's contrast that with the number needed to harm values that are in the single digits, for example. So quetiapine immediate release and extended release, somnolence, NNH of 3, dry mouth 4. For olanzapine fluoxetine combination, weight gain 7, and diarrhea 9. So we're going to encounter those adverse events pretty much routinely in day-to-day practice. Now, it may not be important for that individual patient, not everyone gets it, it's an individual decision, but we need to be prepared to manage it should it occur. With lorazepam monotherapy, it's interesting that there are no number needed to harm values that are less than 10. They're all double digit or higher. So this tells me I'm not going to be as likely to encounter tolerability issues with lorazepam as with the others, and so lorazepam has a more favorable likelihood to be helped or harmed ratio. You're more likely to encounter the benefit than the harm pretty consistently. So this puts it all together.
How do we put this in context when we are treating patients, when you're having dialogue with the patients and choosing a therapy for treatment of bipolar depression in real-world settings?
Yeah, so as I mentioned, we can actually speak this language with patients. They understand the simple concept of how much likely they are to encounter the benefit than encounter a side effect. And you have to select the side effect that reflects their concerns that they are worried about. Now, you can be sure they're all reading the product label. They go online, they read the product label, and they're going to have questions. And they say, doctor, there's a risk of my having sedation or somnolence. I'm worried about that because I need to be alert at my job. So what is the chance of that? Because I read in the label that it occurs, let's say, at 10%. I can't deal with that. So you have to then go through the process of calculating the number needed to harm. And you have 10% on drug and X% on placebo. Subtract the 2, see how many times it goes to number 100. It's going to be over 10. You divide that by the number needed to treat for response, and you can say, well, you know, the likelihood to achieve a response versus dealing with somnolence is like 3. You're 3 times more likely to get that benefit. You don't worry about the somnolence, and if it happens, we'll manage it. So it's very reassuring to patients.
So, well, this will be we're wrapping up for our master's class for today in regard to NNT, NNH, and how I use these calculations in making informed clinical decision for treatment of patients with bipolar depression. Thank you for coming, Dr. Citrome.
Thank you very much for the opportunity. And thank you all for coming.